Hi, I'm Congressman Pete Aguilar. I'm here joined by the CEO of SAC Health, Dr. Jason Lohr. We wanted to have a conversation and for me to ask some questions about healthcare delivery here in the Inland Empire. We know in Washington, D.C., healthcare is under attack. We know that the big ugly law that was passed in July goes after healthcare, but we wanted to talk a little bit about the local impacts because we do see stories nationwide, hospitals closing, clinics closing, millions of people potentially losing healthcare in the future as a result of that law, which also triggered over $500 billion in potential Medicare cuts as well. That has real and lasting impacts to the Inland Empire and to the populations that SAC Health serves here as well. And we know that those are real impacts, in addition to the Affordable Care Act premium tax credits that are also at stake and that provide such an incredible benefit to people to make healthcare more accessible here in the Inland Empire. In the Inland Empire, 21,000 people utilize those premium healthcare tax credits in order to provide care. And those could potentially double the cost of premiums to folks who are using that as soon as next year. And they will be receiving letters now and in the weeks ahead spelling out exactly what those healthcare premium increases would mean for them and their families. We feel that that's wrong. We feel that Congress has the ability to provide support to lower that impact and to make healthcare more affordable now and in the future, and that's what we should be doing. So we wanted to have a conversation with someone who knows what healthcare delivery is here in the region. And so I'm so pleased to have this conversation with Dr. Lohr. Thanks for joining us, Dr. Lohr.
Of course. Thanks for having me.
My first question is, we're here at SAC Health, your new Briar campus here in San Bernardino. But talk to me about how healthcare has evolved here in the Inland Empire and the role that SAC Health has played from its infancy more than 60 years ago to the benefit that we've seen from the Affordable Care Act and what the last 12, 14 years has meant to SAC Health.
Yeah. Well, we started very, very humbly. We didn't have a location in the 1960s. It was 100% volunteers that were coming over from Loma Linda University and helping to see patients who had no insurance coverage. This was back in the 1960s, 1970s, and we would just meet many times in the basement of buildings, right? Building basements. And fast forward, definitely in the last 10, 15 years, we've seen a huge explosion in the amount of patients that we're serving and able to serve, right, with the Affordable Care Act and with so much other ability to cover patients within our region, so that we've grown from, seeing just a couple hundred patients back in the 60s to like 65,000 patients that we're serving today. And that's really because of that growth over the last 10 or 15 years, which is across the board. Not only our clinic, but all healthcare entities can say that the amount of coverage we have today with insurance is more than we've ever seen. And to be honest, we are not looking forward to going backwards on that.
So talk to me about the types of services that you provide, here, because this isn't just kind of an urgent care setting. I mean, behavioral health, women's health, talk to me about the services that are provided through the FQHC, the federally qualified health clinic
Yeah.
systems.
We're very blessed to be able to offer a wide gamut of services and just really wrap around care for our patients. So it's more than just primary care. We have the primary care plus the behavioral health, plus the dental piece, plus specialty care, 44 different specialties. So it's really under one roof where a patient can see all of the different specialties that they could need. And that makes a world of difference for the patient as far as convenience to be able to do that and be able to access that type of a care. We're very blessed to have that type of a full wraparound care. We also have a community resource center. We deal with patients who are dealing with housing insecurity, food insecurity. We're able to have a food bank. We have relationships with Feeding America and other food banks to be able to provide patients, because obviously patient care is one thing. I can be taking care of a patient, but if they need food, if they don't know where the next meal is coming from, then we need to help them with that too, because one thing is for me to prescribe a medicine, another thing for them to actually have access to healthy food to be able to make decisions that are going to help their health long term.
Your view is wellness includes all of that, right? All of those services, all of that opportunity to help people. That's the mission and the focus of what you try to provide.
That's right.
Tell me about the Medicaid cuts that could come. Right, Congress passed these. We've had a number of conversations, about what this would mean. What does this mean? And some of these, realizing that some of these impacts are a little further down the line. 26 and 27 is when some of this kicks in. What would that mean when this fully kicks in?
Yeah.
This law now. What will that mean to SAC Health?
Yeah, it's interesting that most of these changes aren't going to happen until after the midterms. I think that's very calculated and very specific that's when they're going to be kicking in. But the point is, we are anticipating a 20% decrease in the amount of patients that we serve. And so in our community, that means 300,000 patients are going to lose coverage. 300,000 patients, we see those patients every day. I mean, this week, I saw one of those patients. That he's dealing now with a cancer diagnosis and getting chemo. He can't work, and he will lose access with the cuts that are happening, guaranteed.
Talk to me. So someone like that, when this bill kicks in, as you mentioned, conveniently after the midterm elections, what would that mean? Where would that individual be able to go to get care?
That individual is going to be left without coverage, so he's going to have to pay cash for whatever he needs. And how do you pay cash when chemotherapy and treatment for cancer is in the hundreds of thousands of dollars typically? So there will really not be options. I mean, emergency room care, if
Yeah.
he's sick enough to go to the emergency room, but that's just to kind of a band-aid, right? Basically, it's not going to treat the underlying condition that's going to need follow-up for months or even years. It's going to be very, very difficult for a patient like that.
Since the Affordable Care Act, right? That was one of the huge benefits of the Affordable Care Act was just
Yeah.
so we know who the population that we're serving, right? So they don't have to go to the emergency room. What will our emergency rooms, look like if we do? This almost sounds like we're rolling the clock back by a few decades.
Yeah, we really are. We've already thought about that. We're going back, 20 or 30 years. And so the emergency rooms are going to start being, primary care offices, and they're not meant for that at all.
Right.
And so it's just you really it's passing the buck, right? Someone has to pay. Patients are still going to be here. People are still going to be living in our communities. If they don't have the coverage, if it's not covered through a government system, then people are either paying out of pocket individually. If they can't afford that, they're going to the hospitals and being seen in the emergency room, and then the hospitals are taking that cost.
Right.
So at the end of the day, someone has to pay. And we need to have that coverage for patients because without it, they're not going to be able to pay and the hospitals are going to be stuck. It will be a very tough situation for everyone. We're even thinking about going back and offering a free clinic like we did in the 1960s for our patients because if there's no other way for them to be seen, we need to find other ways that are low cost for patients to be able to access care. But obviously, we're not going to be able to do high-end care. If somebody needs chemotherapy, we're not going to be able to provide that. Those patients are going to be struggling significantly.
So that patient that you saw that has, cancer, that would be similar, that can't pay cash out of pocket.
Yeah,
A free clinic might be something that happens in the future, similar to where we were, 50 years ago.
that's right.
Yeah.
That's right.
It's a terrible place, that's the state of what healthcare could look like, here in the Inland Empire. But one of the things you mentioned too, if ERs are going to be, flooded potentially with people, looking for care, that's going to have an impact on everyone within the community. If something happens to your child or something happens to you, the potential impact isn't just the Medicaid population. The potential impact is community-wide. Is that
Yeah,
fair?
no, that's 100% fair because if there's already a wait of hours to be seen in an emergency room, and now it's going to be flooded with patients who don't have coverage. 300,000 patients don't have coverage, and they're going to the emergency rooms. What does that mean? That your hours of wait are going to turn into more than that. I mean, it's
Yeah.
going to be dozens of hours of waiting time. And so, if someone else gets sick, you're waiting in that mix. It's going to impact significantly. Again, it's going backwards, right? We're going backwards, and it just seems ridiculous that we have to be going, backwards right? 20 or 30 years of doing healthcare like we used to do it decades ago.
Medicaid, the Medicaid population, significant group that you serve. Obviously, there's employee-sponsored healthcare that many people have. Although access continues to be an issue for folks who have a card in their pocket, but they can't necessarily see their doctor. And then there's also the Affordable Care Act, premium tax credits, which are set to end this expansion this year. And those are folks who are small business owners in the region, thousands of people who get care through that. What does that mean? If a lapse happens there, what would that mean to the healthcare ecosystem here?
Yeah, and we see those patients under the Cover California program. And so those patients right now, we anticipate that we're going to lose half of those patients because the cost to them is going to double come January. So we've already been told by the health plan that to expect to see a reduction 50% in those patients. And we see those patients too. And there typically are, I've met multiple small business owners. So these folks don't have insurance through their company.
Right.
They have to pay out of pocket for their coverage, and they can't afford to pay a house payment for healthcare. And that's what it was previously. It was close to a house payment for healthcare. And so with the subsidies, they were able to access healthcare at a reasonable price. And if that ends, those folks are not going to have coverage. And they're working folks, middle class. They're the backbone of our community, right? They're
Yeah.
running businesses. And just because they're not working with a large company that provides healthcare doesn't mean they shouldn't have access to healthcare.
Being a small business owner shouldn't mean that you have to take risks with your own healthcare. I mean, the benefit of the Affordable Care Act is that it really put, that and these premium tax credits really made healthcare more accessible to those people who weren't on employee plans. Those are, populations that you serve, and that's the importance of the moment that we're in. But SAC Health also has such a geographic diversity of the population that you serve. Talk to me about the difference between urban and rural settings, and how difficult it is for people to be served in rural communities, and what this would mean for the Medicaid population, for the healthcare.gov population. Will there be fewer clinics and fewer hospitals in rural settings?
Well, we're already dealing with that, right? So we have clinics in Blythe, we have clinics in Barstow. Right now, the hospital in Blythe is struggling. And in fact, we don't know how long they're going to be able to keep their doors open to the population. And hits like this are going to only worsen that situation. So the chances of them being able to survive, continue hits are already in that rural setting, trying to recruit, trying to retain, having to pay higher salaries for people to work in that setting, and then not having the higher reimbursements that typically will come in that setting. That has been very, very difficult for our rural hospitals to stay alive. We also see patients from the whole 395 corridor, and we know that even the hospital in Bishop is struggling right now too. So these are making news, right? I mean, they're in the news now with these hospitals that are struggling, and that's before any of these cuts we're even talking about.
Yeah.
So once those cuts come into effect, if these hospitals are even still with us, what that means afterwards is going to be devastating for our rural communities. And we see those patients. We're in those communities, and we see patients that drive from those communities to be seen in our clinics.
I mean, in hospitals, by law, they have to serve people, right? Anybody who walks into an emergency room, without getting into all of the financing of hospitals that you and folks in the community have taught me, with the Medicaid population, we get one reimbursement rate, that's roughly maybe 80 cents on the dollar of what it costs to provide that care. If someone just walks in and they don't have health care, uncompensated care is about half that, right? And so that difference, the local institution, the local hospital, local clinic, all has to absorb that. Is that fair?
Yes, that is fair. And that goes back to our earlier point that somebody's paying, and now we're shifting the payment and the burden of the financial cost to the institutions, to the healthcare institutions, which are not going to be able to sustain it, right? Maybe the big ones can sustain it for a short while, but the smaller ones will not be able to sustain it. And so there's just no other way around it. You will have hospitals that have to close.
you're the CEO of the system, but you also are a doctor and you still provide care in the example that you gave before. What is this going to mean to areas like the Inland Empire? You've seen this area, grow. I remember giving speeches 20 years ago saying the Inland Empire is 2 million people and we're growing. We're 4.5 million people now in this region, and we continue to grow. What will these cuts mean, to the Inland Empire? How will people feel it? How will everybody feel it?
Well, when you're talking about 300,000 people, that's not a small amount, right? And those folks are losing their coverage. That's going to happen here in the next 18 months. 300,000 people even out of 4.5 million. I know when we talk numbers, it's easy to just get caught up in numbers and be like, well, what's 300,000? But that's like each individual is a family, represents a family, represents a person, represents they're a member of the community. So, when one person in the community suffers, then others suffer, right? Their neighbors, their friends, their family, their extended family. There's no way that there's not going to be an impact, right? It's just that's how things work. And that's a significant impact. I mean, we're not talking about just a couple hundred people or even a couple thousand. We're talking about hundreds of thousands of people losing their coverage.
When we talk about a community, we also have to, think through, there's a lot of disinformation that's out there on immunizations and vaccines. Tell me what that means as someone who, puts science first and wants to help people and is balancing, your training and your mission of serving people with this raw science of vaccines helping folks. Tell me how we can continue to keep in this community ecosystem that you talk about, how we beat back the misinformation and disinformation and continue to support, delivering vaccines to families.
Yeah, no, it's a great question. We continue to focus on the science, and all of the physician associations continue to focus on the science. So that's not changing. So if there is something that changes at a federal level, we're still going to continue following what the physician associations support and the science supports. And so we continue to tell our patients about that. It's interesting. I've noticed in the last week, my patients have been more interested in getting vaccinated than they've ever been.
Oh,
And
interesting.
I don't actually know exactly why that is, but I think maybe they're realizing they just need to focus on the science
Yeah.
and that they're not going to listen to others that aren't focusing on science. They are going to listen to what their doctor recommends and what science recommends because they know who the experts are that they should be asking. So I've noticed that. So I hope that's the case, and I hope that patients will continue to focus on that because ultimately that's the best thing. I mean, we've got decades of data showing the effectiveness of vaccines. And I know this is a little bit more on a personal note, but I have lived in countries where I saw patients die from vaccine preventable diseases like tetanus. Tetanus is very rare in this country, but it's only because we vaccinate. In other countries that don't vaccinate, I've seen patients die from that. So I know the impact of people who don't get vaccines that they should have gotten.
I mean, so what's your advice to families who are thinking through this, right? I see politicians saying, don't do this. Isn't the answer, ask your doctor,
Yeah.
ask someone you trust, ask someone who's providing your care.
Who's the expert, right, in health? Who's the expert in vaccine? It's going to be a healthcare professional.
Are you telling me politicians can't be experts in all things?
I think politicians can be expert in their area, politics, right?
That's fair.
You
That's
know,
fair.
but in healthcare, leave it to the healthcare professionals to make that decision, and leave it to the data that's been there for decades and decades, and has been shown to be reliable, and it's good data. I mean, it is, and we have to probably do a better job even as healthcare professionals getting the word out and showing the data. But we have very clear data that shows exactly what we should do. I mean, this whole thing, even on Tylenol and pregnancy, is another issue. It's like that we have clear data showing that. And so I think, yeah, stick with the healthcare professionals when it comes to healthcare.
But
Stick with other professionals with
I don't
with
take
other
offense
areas.
to that. I don't take offense to that, quite honestly. But I mean, trust the science, right? Follow the data
Yeah.
and ask your doctor. I mean, it just seems that simple.
Yeah.
Thank you for the work that you and SAC Health, does here in our community. Hundreds of thousands of people who you are treating in beautiful, facilities that take away the stigma. of indigent care, right, and provide care to so many people. You folks are the backstop, here, and you do it in such a professional and honest and straightforward way. Dr. Jason Lohr, thank you so much for taking the time, for having this conversation, for dispelling some of the myths that we see, but also talking in plain terms about the impact that the Republican Big Ugly Law could have on healthcare in the Inland Empire, what that means to residents, what that means to our communities. I appreciate you taking the time.
Of course. Thank you.